we will wind up our evening session with this. Welcoming Dr. Arvind Sukumaran, who will now talk on traumatic brain injury long-term follow-up.
Sir, good evening, sir. Welcoming you, Dr. Arvind Sukumaran. He's done his postgraduate fellowship in epilepsy, functional surgery fellowship, and University of Ghent, Belgium. Pediatric neurosurgery fellowship, Alberta Children's Hospital, University of Calgary, Canada. Epilepsy functional surgery fellowship, Foothills Medical Center, University of Calgary, Canada. And senior consultant neurosurgeon, Apollo Proton Cancer Institute, and senior consultant neurosurgeon, Apollo Children's Hospital.
Thanks a lot, Dr.
Thank you, sir, for coming over. Kindly take over the podium.
So, thanks a lot, sir, for this wonderful introduction. So, before I start my topic, I just request all of you to kindly excuse my occasional snorts, sneezes, and coughs. And I can also reassure the audience that I'm not going to spread any bugs to any of you. So, that disclaimer apart, let me go to this topic of traumatic brain injury with long-term follow-up. This is, to put it in perspective, this is a question, this is a topic that might answer the question, did your mother drop you? So, that's how I would say this. So most of them, when children grow up and if they have some deficits, that's exactly what we would be answering. So before we start, we should know why are we talking about certain things. So the first thing, what is the burden of traumatic brain injury in India per se? No, this is about both the adult and the pediatrics, and they take about 3% of our gross domestic product. And we have about almost 4 to 5 lakhs per year of pediatric traumatic brain injuries because they constitute about 25 to 30% of the TBI. And as such, the burden in India, we do not have a very robust data collecting system. However, there has been a study from AIIMS Delhi wherein they took children below 16 years and they examined, and they found that about 31% of those TBI children were the pediatric age group, and even in those patients who were admitted versus non-admitted, even in the unadmitted patients, there is those who are being sent back, there was a 3% mortality. So this is something which might be surprising because it is very important to know that just because a patient is not being admitted, that doesn't mean the patient was not serious. Unfortunate reality is that in many of our institutes, there is a phenomenal space and resources constraints. So here we like to salvage the patients where we can. So many a times very serious patients might be sent off to the nearby hospital. And for example, in this case in AIIMS, as I know that more than 2 to 3x of the patients, they go to the adjacent hospital called the Safdarjung Hospital. And if you see the next graph, you can see that there is the gray is the moderate injury, the black is the severe injury, and then the striped one is the mild injury. You can see that consistently across over the 4 years, the moderate injury has been very low. It is not that it is low, but it is because the clinicians find it easier to categorize the patient as severe or mild rather than putting them to moderate. So it is kind of an observer bias which will always be active. So that is the reason why the moderate injuries are less. I don't know. Where should I direct this to? Okay. So before we go into the topic, there has to be a basics of TBI. Whenever we always talk about the Glasgow Coma Scale, and mild is 13 to 15. So the first line, I'm going to start with a controversy. So here, is 13 included in mild or moderate? That in itself is a controversy. Though the CDC and the international guidelines categorize 13 as mild, many times in most of the series, they take 14 and 15 as mild, whereas 13 is categorized into moderate. So it is very difficult to extrapolate the results because 14 and 15 are entirely different species together. In my opinion, 14 and 15 should be mild and 13 has to be in moderate. But that's exactly not the case. So whenever there is a mild injury, there are very telltale signs and symptoms wherein the CT scan is ordered. Excuse me, where should I direct this? It's just not happening. It's quite slow to respond. So there for various age groups, there are various kinds of the Glasgow Coma scales. Can you please? should I in that direction? Yes. That's okay. All right. So what are the aspects of, my topic is about the follow-up in traumatic brain injury. So what are the aspects towards it? First is the physical component, then the cognitive, the sleep, and then the socio-emotional. So these are all the four paradigms in which we are going to evaluate the patient or go for the follow-up. So whenever it's the physical thing is involved, obviously the physician is going to be there, a physical therapist, occupational therapist, respiratory therapist, a personal care attendant who's going to be with the patient, whether it could be a caretaker from the family or someone who was hired to do the same job. And of course a visiting nurse who will be able to provide a trained resource. Cognitive, again there is a speech therapist, occupational, educational and neuropsychologist and a physician. Sleep, same thing. And then the socio-emotional, here you have to involve the social worker, the education specialist, the neuropsychologist, physician and the counselor or the psychologist. So all these together are the aspects in which we got to follow up, and this whole team is required to deliver good result to a child. So what is a team? It's a huge one. It's famously said that it takes a village to raise a child. It also takes the same village or even a bigger one to save a child. So the component being the physician or the surgeon, and these are the fulcrum around which the whole system rallies. They have to rally up all the other resources and provide the best possible outcome. So that involves the surgeon, the pediatrician, the psychiatrist, the psychologist, the social worker, occupational therapist, physiotherapist, speech, swallowing, and of course the dietitian. So all of them have a role to play. So whenever we counsel the patient, I'm guilty of doing the same. So in my early stages, I always said that, okay, trauma is a one-time insult, so it can only improve from now. That's a very reductive way of thinking. Actually, it is not. So if you can see this, the graph on the right corner, the top, you can see that the striped one and the black, that means there is a decline in the IQ. So what that means is 1 in 3 actually decline from made gains. That is, in the first 1 or 2 years to 3 years, they will make a gain in their cognitive aspects, and then that will dip. So there is a decline in about in about 10 to 15 years. So the question here is traumatic brain injury a single time event or is it a continuum? So there are multiple studies that say even a single brain injury can accelerate the aging process. In this study from in brain pathology by Johnson et al., they identified that neurofibrillary tangles, which are kind of synonymous with aging and Alzheimer's, they are found in less than 60-year-olds, in about 34% after 1 year of trauma, and in only 9% when it's only a control. And there has also been documented increase in the Alzheimer's, PD and dementia after moderate and severe TBI. So the next question is, we always think that the child's brain is growing. So there is a lot of scope for plasticity. So the younger children have better plasticity, so better improvement. So this is the common reductive way of thinking. Again, it's entirely untrue. Actually, it's the opposite. So that's only bad news here. But the problem here is the adult suffers impairment of specific functions already acquired previously. So it could be a focal loss. However, a child suffers the impairment because of the ability to, disability to acquire and develop newer functions and structures. So in a way, this plasticity, I wouldn't call it, the growth potential in itself is a liability for a better outcome. So here we need to know relevant jargon. So because my presentation might take longer, I'm just leaving this. This is actually a very important study which has to be highlighted, and in which they have found out what are the myths. Do the children follow up after traumatic brain injury? So they had 352 children from 2 to 18 years, and they found that only 20% of them never turned up for any kind of follow-up, and 27% had partial adherence to the regimen, while 53% of them were fully adherent. So they categorized this as unmet needs, met needs, there was no need, and then some of them it was unrecognized. They did not even know what it was. So there was various categories in this, and you can also see that over a period of time there is also change. So this the right side graph says in how many of them there was a change in the category of need. There is some might think that there was no need, but then after 3 or 4 months, they will say there has been some cognitive problem. So yes, then they will go for the counseling. So in this case, there is a change in the categorization. So it is a very evolving and a dynamic process. It is not a single time process. So the other thing is, when we talk about the traumatic brain injury, once the acute problems are tided over, follow-up strategy is the same, whether it is a moderate brain injury, severe brain injury, or the same. We have to take care of the sequelae, which could be spasticity, which could be hydrocephalus, anything, but all those are acute problems. Once that is crossed over, then it's the same. You have to identify about the cognitive, the functionality, the occupational outcomes, so on and so forth. So this is the only, it's a very good prospective study from 2 to 7 years age group from the Royal Children's in Melbourne. They took basically 4 time points over 10-year period, and then they chased the outcome and the IQ. So the bad news is that the children do not grow into the deficits as said earlier. There is no spontaneous catch-up. There is only an increasing or widening gap in IQ between the control and the patient, which stabilizes around 5 years, but it remains the same. So the mean IQ deficit of severe TBI to control actually we see is about 18 to 26 points, even at 10 years after the injury. No. I'm skipping over this. Okay. So this is another very counterintuitive point that I would rise to make. So we always think that, okay, if someone's really brilliant and they have a fantastic IQ, their recovery potential is higher. Actually, again, it is not. The bigger they come, the harder they fall. Higher the pre-injury IQ, the greater the loss of IQ points. Maybe their baseline IQ is still higher, but that's questionable. There is no data regarding that. However, it is given that in a higher IQ patient, he might not achieve the same level of functionality as he was earlier. So that is the bad thing about it. And here we see that in about 97% of the patients, the recovery kind of plateaus. It almost reaches the 98% of the improvement by about 18 months. So here I'm going to concentrate more on mild traumatic brain injury more than any other, because those are actually being covered by the surgeons or the neurologists, and then once the acute phase is over, they come over to the same aspects of management as you would do for a mild TBI. So I'm skipping over the definition of mild TBI, which I think we already went through. So this is a very, very important study in that context regarding mild TBI, where they chased about 42,000 patients, and they just excluded the trivial injuries that included the abrasions and the lacerations. And the outcome was that only in about 5% only had loss of consciousness in this, and among that only 3.7 had a clinically important TBI. CITBI means clinically important TBI. And similarly, about 11% had altered sensorium, but only 4% among them had a clinically relevant TBI. And they also categorize the mechanism of injury, what is mild, severe, and then moderate. And according to what type of the mechanism of injury, actually, they categorize how many of them had actually the mild TBI, the moderate, or the severe. This is one of the most important things which I would like to highlight. There is what is a second impact syndrome. This is widely not recognized or known or acknowledged. This is basically a second head injury before the complete recovery from an initial head injury. So, and this can occur both in adults as well as in children. The first injury kind of, they might even be normal, or they might have only mild concussive symptoms, wherein there is an array of neuronal, metabolic, and ionic changes. However, whenever there's a second hit, it has a multiplicative, or rather even an exponential effect rather than even an additive effect. So there's a legal law that says that once there is a concussion, he cannot resume the game or the sport that he was playing earlier. So there is a subset of patients in which it persists for beyond 2 weeks and continue for more than 3 months, sometimes even a year. So what happens? And that is exactly what is called as a post-concussion syndrome. So this is where we need follow-up. About 70 to 80% have no perceptible symptoms beyond 3 months. So what happens to them? We will come to that later. There is documented evidence that just simple early counseling, that is on the coping mechanisms or what to do about even imparting knowledge about the second hit syndrome, has improved outcome even at 3 months. And there are certain premorbid conditions that can delay the recovery, and there are also other factors that predict the longer outcome. And then there are validated scores to predict the post-injury concussion. So these are some of the premorbid histories, which include lower IQ, pre-existing psychiatric neurological disorder, pre-existing learning difficulties, and of course the lower social and economic status with the family, societals and stressors. I'm skipping over this. So as I said again, about 70 to 80% do not have anything more than 3 months. So what about the rest of the 20? The other 15 to 20, you have to do a lot of tests. You have to take them for neuropsychological assessment regarding the symptom, the cognitive function, as well as any other residual injury. Further detailed imaging with an MRI, with SWI that shows microhemorrhages, and functional imaging, that is the bold sequences, and the tractography, which can show the shearing of the neurons. That is also recommended. But the basic management concept is that you have to have uninterrupted rest during this phase, and there should be reduced focused activity, which means reduce the electronics and the media. And there should be reduced focused schooling. Do not send them to school. So there is again documented evidence saying that continued schooling or electronic usage during post-concussion syndromes has prolonged the syndrome. So these are all the features to watch for as a responsibility of the parent, and to elicit as a responsibility of the physician. So again, there are 3 domains which would include cognitive, physical, and the emotional. I'm not going to talk in detail about them. So the other big question here is, whenever there is a mild traumatic brain injury, do we have to do a follow-up imaging? So we always have this concept of a discharge CT. Actually, it might not be necessary. If there are new symptoms, then yes, of course, it's very important. If there are no symptoms, even to justify that the number needed to treat is about 305. That is, you have to do 305 CTs just to have one finding. So which is an obvious wastage of the resources. But on the other hand, just think about it, but in a center with 10 such CTs done every day, you can catch one patient a month. For example, in a place like Nimhans, you might be able to catch 1 or 2 patients a month, which you might not. So I think in those kind of places, it's still worth doing. And then the follow-up imaging, factors associated with the higher rates or intracranial bleed, PQ admission, and the mean total length of stay in the ICU. So even after a normal scan, there might not be much change. But this PACU admission and the increased LOS is just a surrogate for increased severity of the injury. And as such in mild TBI, up to 1 year of age, it's more of a parent-reported issue. Maybe it's because the child is more with the parent, while if it's older, it's more with the teacher-reported issues. And there are also studies that say that increased length of hospitalization is associated with increased depression in the patient. So we also see that the in post-concussive symptoms, more than a month, which is lasting in about 30% of the patients. So I'm not going to go into the complete detail here. This is a very common question. All the parents, after any kind of an injury, they will ask whether is my child going to have a normal intelligence. This is a common question that anyone's going to ask. So to answer that, there was a meta-analysis in which they say that in the subacute phase there was no difference, but in the chronic phase there was a difference. In that, if it is a mild, in terms of IQ, children have a better long-term outcome in mild TBI as compared to adults, and a worse long-term outcome in case of severe TBS as compared with the adults. So here, this is the post-traumatic epilepsy. We see post-traumatic seizures. Okay, we have to make a distinction between the seizures and the epilepsy. Seizures is a one-time event, while the epilepsy is a propensity to have more such seizures. So post-traumatic seizures are seen in about 5 to 21% of our population. In a very good study published in 2011, out of which 30 to 40% have recurrence which become epilepsy. So the generally accepted rates of post-traumatic epilepsy as such is only 3%, while the general population rate is about 0.7, which means there is almost like a fourfold increase in the rates of seizures. And a very important thing to note here is the mean time to onset of the late seizures or the epilepsy syndrome was almost like 3 years. And it doesn't mean only those who have had an immediate post-traumatic seizures will have this. Most of them did not have it. This is a very good Indian data, albeit old. This is quite a robust one. I think I have to go back. Yeah. So this is the only Indian data that we have currently, in which they say that the GCS and the longer loss of consciousness time directly correlate with the incidence of post-traumatic seizures. So with this, the question here is, do we give the anticonvulsants? Yes, if there is a documented epilepsy, that is, if there are recurrent seizures, obviously you have to give the the anticonvulsant. However, giving a prophylactic drug is quite controversial. Generally, I consider this whenever the child is less than 3 years old, when there is a severe edema in the first scan, when there is a parenchymal injury, intraparenchymal, either it could be an edema, focal edema, or it could be the bleeding, if there is a depressed fracture and a subdural or subarachnoid hemorrhage. What if there is an immediate post-traumatic seizure? In this case, again, I generally give it, but I would like to stop it within 1 week. What is the choice of drug? Earlier, it was septoin. There is a diphenylhydantoin, but there are studies that says that even a single dose of diphenylhydantoin can have long-term neurocognitive effects. So the current choice is either levetiracetam or brivaracetam, depending upon how they take it, because levetiracetam has a higher chance of having agitated or a violent behavior. So this is a very interesting thing called a growing skull fracture, wherein the patient will just present to the physician with a small swelling in the head. They might not even know that they had a fall. So what exactly is it? Is it growing skull fracture or a growing skull fracture? Both are right in that one of them is the etiological explanation while the other is a morphological explanation. It occurs only when there is an enlarging brain, which means it's going to be happening in less than 1 year of age. At the max, it is only 3 years. Yes, there are documented case report level studies that say even about 10 years, but I don't think we cannot take exceptions as examples. So basically, it is nothing but an increasing width of the fracture. And the theory was that the pulsatile brain retracted the dural edges, did not allow it to fuse, and then it also increased the size of the fracture. And the treatment for this is craniotomy and the dural repair. So in this is the kind of patient in which you have to follow for a minimum of 3 months. So you can see that there is a fracture here and the brain is herniating through it, pushing the bone edges apart and not allowing it to fuse. And this is the algorithm that we use to decide what to do about it. Any children less than 3 years with a pulsatile mouse, it could even be non-pulsatile if it's increasing. And we will have to consider this entity. Still, you can wait for about 2 weeks. If there is no increase, then that's called a pseudo-growing fracture. Otherwise, we can use it. So this another important thing is, this is all special cases in which there is a neonatal traumatic brain injury. It happens. Even with a normal vaginal delivery, there is about 3% chance of having an intracranial hematoma. And with the instrumentation after failed LSCS, it's almost about like 26%, while instrumentation is being used in about 10 to 15% of all the deliveries that happen. So rarely this can also produce something called a growing fontanelle. It is the equivalent of the growing skull fracture, but through the fontanelle. So in these cases, the immediate outcomes are generally good after the repair, and generally we try to do the fast sequence MRI instead of a CT because of the radiation to the growing brain. And if the fontanelle lacks, anyway we are not going to do any kind of imaging. And generally in children, neonatal, this thing, even if you find an obvious cause for the hematoma, it is always wiser to go and do a workup for the bleeding diathesis. So there has actually been no long-term outcome studies on the cognition. I request any high volume center to please take it up. And what about the inflicted injuries, or the so-called battered baby syndrome? It is as much of a social problem as it is physical. So typically you see a child less than 2 years brought just with lethargy and feeding issues and some bruises, and with a vague and non-specific history. So in these kind of patients, they identified that whenever it's in a less than 2-year-old child, the cranial issues have they take more importance than non-cranial issues. Well, it's the vice versa. In more than 2 years, it's always the other issues that have more importance than the cranial issues. We do have to inform a child abuse social worker, but in many of the hospitals or setups, we do not have access to such a machinery. So it is a problem, because the question here is about, we cannot primarily prevent it because we never know what's going to happen. It's basically a reactive prevention. That's how I would like to call it. So it is said that in undiagnosed battered baby syndrome, there is a 10% chance of the next ER visit happening within the next 1 month. And 1/3 of the patients have already had a prior visit. So all this should alert us to this concept of battered baby syndrome. And this is the most difficult to follow because the parents will not bring, but however, this is the most essential to follow up also. So the outcome is that, as we see, 2/3 of the patients have developmental issues with gross learning disabilities. Sometimes whenever there is a panhemispheric damage or a diffuse atrophy, they are basically non-functional. So when would you want a longer follow-up? Generally, it's about 3 months. But when would I want a longer follow-up? Whenever the age of injury is less than 6 months, and there's a documented bleeding diathesis. Whenever there's an immune thrombocytopenia, VP shunt, because that changes the pressure dynamics of the brain, and also neurodevelopmental disorders and drug alcohol intoxication in case of adolescents. So as a take-home message, I would say that post-concussion syndromes symptoms disappear about in 30% of the patients by 1 month, 15% by 3 months, and 5% in 1 year. And the domains might be somatic, cognitive, affective, or sleep. And the deficits correlate with the severity of the injury. Younger the age of injury, more the disability. Catch-up growth into the deficit is just a wishful myth. And for mild traumatic brain injury, follow-up is for a minimum 3 months. It is a multidisciplinary approach. Please try to treat the patient with the disease, not just the disease in the patient. So I hope that this gives a scientific basis to answer this question, did your mother drop you on your head? So with that, I conclude my speech. Thank you.
Thank you, sir. Sir, you are given almost like an algorithm on how to, for the pediatrician level, how to approach the child who has come with concussion injury to the brain. And they also tell that 3 months follow-up is mandatory. Actually, generally in our setup, once the acute phase is over, and we tell them maybe the first follow-up they may come, or sometimes they may even call on the telemedicine. But unless we are insistent that they have to be followed up, I think we should use more categorical advice that they should come for a 3-month follow-up for us to give a clean sheet at the end.
So because of the barriers, I think even telemedicine is not bad. Most of the times we want the history from the parents. Even a telephonic interview. During my 2 years in Canada, it was the COVID time, so most of them were not asked to come physically. So there was a study after I came regarding what was the outcome in those patients between the telephonic interview vis-a-vis those who had only a regular direct. There was not much of a difference. So at least we should have, if they have a difficulty in coming to us directly, at least there should be some kind of a telephonic or a via media.
Yeah, unless we create a system involving the social worker.
There should be a follow-up. Yes.
Thank you, sir. Any questions from the audience? I think we can call the session now. Thank you so much, sir.
Sir, I request Satish sir to honor the 2 previous speakers with a memento, please. And with that, we come to the end of GDBPCON 2023. It was a pleasure and honor having all of you here for the 2-day academic festival. We hope GDBPCON 2023 has bridged the quality gap as it had promised. I request all of you to assemble in Hall A for the valedictory function, and we hope to meet you all again in GDBPCON 2024. Thank you. Till then, bye-bye and take care.